Welcome back to part 3 of the Baba Yaga of Airway, Lingual Tonsillar Hyperplasia. I know this slide, this backboard, my drawing board is a little busy, but it's used as an outline, okay, to talk more about this topic. So, lingual tonsillar hyperplasia. The etiology is unclear, such as they associate with obese patients. Maybe it's a side effect of chronic infections, GERD, allergic reactions, or maybe compensation for prior ENT surgery. Okay. Now, it's lymphoid tissue that forms at the base of the tongue. Okay. And that's usually, it's one of the most common causes of the unexpected difficult airway in the patient that you predicted was going to be a normal airway. Okay. Now, this lymphoid tissue can develop in this area of the vallecula. Okay, sometimes people draw, can visualize the vallecula like this, and the epiglottis, which is like cartilage covered in soft mucosal material. It's basically this is the vallecula at the base of the tongue, and this hood it goes up and down. Covers your vocal cords and prevents you from aspirating when you eat. Now, the vallecula is here. This is where our MAC blades were the most commonly used laryngoscopy blade that we use for intubation fits. Okay. Now, this lingual tonsillar hyperplasia can involve the entire vallecula and push down the epiglottis and almost theoretically cause an airway obstruction. So it makes it almost impossible to see the vocal cords when you try to intubate with the DL blade. And it may almost look like an extension of the tongue. And you may not even see the vocal cords because it's so anterior now. All this material at the base of the tongue makes it look like an extension of the tongue, and I see only tongue or material like that looks like tongue. I could also cover the lateral aspects of the epiglottis, overlay the tip, like right over the epiglottis, or it could be the whole combination, the entire vallecula, the tips, and the lateral aspects of the epiglottis. So now you see me, or now you don't. Okay. So the patient can be asymptomatic from this disease process, or have symptoms that contribute to their sleep apnea, or cause some dysphagia, problem swallowing, like some discomfort when you swallow. And you would only figure that out through maybe a lateral X-ray or a CAT scan, or an ENT doctor scoping you and diagnosing this. Okay. Or in the unexpected failed airway. If you survive that incident, an evaluation is usually done afterwards to confirm such diagnosis. Okay? You won't pick this up on a normal routine physical exam. Nothing you palpate on the outside will predict this. The tongue depressor on the tongue, look in the mouth, won't predict this. The Mullen Potty score won't predict this. Okay? Dr. Ovasapian, he's from Chicago. He's since passed away, but he is one of the most published persons in fiber optics, in anesthesia. All anesthesiologists will know him, at least if you're part of the Society of Airway Management. And he's written books about fiber optics, and he's diagnosed this problem. And then he did a case series. He led us an article, and in which the article described 33 patients who had an unexpected failed airway. Could not intubate them. In those patients, they were trying to find a common characteristic. Of these patients, in their first incident before their failed airways, there was an airway risk score that was done. 65% predicted a 95% success rate with intubation, based on the scoring system that they were using for these patients. Now, what did they find in the study? And all these patients that they did not predict this difficult airway, the failed oral airway intubation. They found that 12 of them wind up also having difficult bag BVM mask ventilation. And they were trying to assess what were the common characteristics again. 15 of them had a Montpellier score of 1 or 2. 10 of them had a Montpellier score of 3. 6 of the 33 were obese, but most of them were at the trunk and the lower half of their bodies, not their neck or chest. And 5 of them had some limited neck movement, limitations and extension. The only one true characteristic that all these patients had, unexpectedly, lingual tonsillar hyperplasia. Okay? So, this may be something you predicted because the patient had a history of difficult airway and it was diagnosed with lingual tonsillar hyperplasia. For the majority of us who don't get a history, like a paramedic, because the patient's obtunded and there's a clinical conditions preventing us from getting this history. Patient's a poor historian. There's no electronic medical records. All the paper charts at your hospital. No one will be able to tell you, except for the patient or family members or his private doctors, what he has as a problem in his airway, regarding his airway. Because if you do give RSI, and the majority of us do in the ER world, at least the ER setting, and some of us in anesthesia do, you paralyze this patient. Whatever tone it was in the skeletal muscles holding up his neck and holding up the airway, preventing him from collapsing when he's awake but not paralyzed or induced into a coma from RSI or from our drugs that we give for sedation. Once you give the paralytic, the muscle paralytic, whatever tone holds up this neck or the areas in around this glottic opening, you will paralyze him and now the airway that had some obstruction from this peritonsil abscess will collapse completely and will drag with gravity downward and complete your airway obstruction. You know how you're going to diagnose this? Either you visualize what the heck is the soft redundant tissue at the base of the tongue and developing and collapsing all over my DL blade and I can't see anything. You're going to have some difficult bagging. And hopefully success and sats are staying up over 90. But you will have patients who will fail bagging. So you're going to use an LMA, perhaps. Because you believe in your LMA. And hopefully you're lucky, like a patient I took care of earlier, and be successful with it. But a lot of times, all this that's causing obstruction is going to prevent a good seal of the LMA covering the glottic opening to prevent the LMA from being successful in oxygenating and forcing air into the cords. So you better have a King LT. And that's the product I use in my shop, and it works well, especially for this instance. Okay? And there are case reports about that King LT succeeding where the LMA failed, or things that look like an LMA failed in this setting of lingual tonsillar hyperplasia. All right? Emergently, you figure this out. Oh my God, this is a role for the DL blade, right? Getting around the tongue, around the corner. That's what the DL blade does. It looks for the anterior airway, okay, where your DL blade cannot, okay. Or you can use a Miller blade, the blade that's suggesting in difficult airway algorithms, but almost no one ever uses. So because no one ever uses it, their skill set and skill level at it is not expertise. It's horrible. And remember the last time they practiced on it in either the OR or on a mannequin. But most people lose skills that they never get practiced. Okay? Hopefully, you have a chance to oxygenate this patient successfully. Hopefully, if you had something better than a King LT, like an LMA that allows intubation through it, you can oxygenate the patient and through the LMA intubate with fiber optics. That would be ideal. The King LT, the way it's set up, you would have to do a lot of different steps. It's a lot more difficult than people realize, using a pediatric fiber optic scope, using a hollow duct bougie, which is like an ARD catheter. Because once you preloaded this fiber optic scope and see the cords, you use this almost like a bougie, like a Sellinger technique, push it through the cords, leave that in, take out the King LT, and then put an ET tube over it. Not many people carry a pediatric fiber optic scope. But that's a scope that fits in our King LT, the apertures, the openings. All right. You keep using that MAC, trauma, all this lymphoid tissue gets bloody. It becomes more of a bloody mess. All right. Now, if there's patients that can't intubate and that can't ventilate with the BVM, LMA, King LT, do not hesitate to cut the neck. There is a case report by Schroeder who describes a retrograde intubation through a guide wire, stiff wire that's designed for this, that goes through the neck, comes out through the nose and the mouth. You clamp that wire and push an ET tube through that wire, through the nose or the mouth, and hopefully when there's hold up in the neck, you can release the guide wire, take the guide wire, and feed the ET tube into the cords. It's been described, not made up. Schroeder has an article in Saudi Anesthesia publication, okay, 2010. Or do you use the regular surgical crike? If you're not comfortable in doing it, you better call your ENT or surgical colleagues to do this. But if you're an ER doctor, you paralyze this patient, you better be ready to cut the neck. All right. If you didn't know about the lingual tonsillar hyperplasia, if you don't know, now you know. From a famous rapper from Brooklyn. Okay. Now, the one thing. There is, I think, a Dr. William Rosenblatt in Yale, and he has resources to use a fiber optic scope to pre-screen all his patients. I don't have that luxury. The administrator would kill me if I used that much money for resources of the fiber optic scope, risking it getting injured or damaged, and getting it cleaned every time I needed to scope a patient, every time I intubated them, to evaluate the airway, to predict what devices I need to use, or if I need to use fiber optic only intubation. And if I did have the chance to do that, I would diagnose the lingual tonsillar hyperplasia and probably do an awake intubation with sedation and no paralytic in an upright position. Ideal in a perfect world, that's not the world I work in. So, the Baba Ya of Airways, lingual tonsillar hyperplasia. Thank you. I will have articles up to read more and to refer to based on the descriptions I've gave here. But if you want to do more further reading, I'm not making this up. I've experienced it. Hopefully you don't experience it, but if you do, hopefully you're prepared. All right. Thank you.